So it's going to be a really enjoyable day today, and thanks for tuning in. As Bill said, please submit your questions during the Q&A. And I'm going to turn first to Dr. Brett Horowitz. Brett's an orthopedic surgeon, and he's a leader in our musculoskeletal program. And he's going to tell us about a particularly special patient encounter that he had through eviCore. Brett, welcome.
Great. Thanks, Eric. So this case demonstrates the usefulness of our evidence-based guidelines and our prior authorization process as it relates to a total knee replacement surgery request. These evidence-based guidelines for knee replacement involve criteria for the severity of arthritis, which is based on X-ray findings, the degree of pain, and also that a reasonable trial of conservative treatment has been attempted. And the most important criteria, however, involves a documentation of the severity of arthritis as identified by the X-ray findings. If the X-ray criteria are not met, then performing a knee replacement may not be appropriate, and other potential treatment options might be better suited for the patient and should be considered. In this particular case, the degree of arthritis was minimal and did not meet the guidelines for knee replacement surgery, and therefore the request was denied. A peer-to-peer conversation was then offered with the provider in order to discuss the patient further and to obtain any additional clinical information that might result in either an approval or an alternative recommendation for this patient. During the peer-to-peer discussion, the conversation led the provider to recognize that although all other criteria for the joint replacement surgery were met, he agreed that the X-ray findings were insignificant and did not correlate with the level of pain around the knee area. So this then led to further discussion to consider other sources of the patient's pain. And at that point, we discussed the source of pain could be referred from other anatomic regions. And I suggested that he consider evaluation of the hip and spine as potential pain generators, since both of those anatomic regions are known to refer pain to the knee area. He later re-examined the patient and obtained X-rays of the hip, which then confirmed a diagnosis of severe end-stage osteoarthritis of the hip and provided confirmation that the pain generator in this case was indeed the hip and not the knee. So he was thankful that the prior authorization process steered him in the right clinical direction and ultimately avoided unnecessary surgery for this patient.
Brett, really, thanks for sharing that. It's such a powerful story. And, and here's a perfect example where if you just look at, if you just were to look at the paper, you would say the paper guidelines, you would say, well, okay, this seems to meet criteria, but taking that deeper look and really applying the evidence to the individual patient helped to realize that although the patient's experience with pain was in the knee, that it really just something didn't fit. And we avoided going through a costly and painful recovery for the patient, which wouldn't have ultimately resolved his pain. He still would have needed to go back and deal with the hip. So right. Not only did it avoid that procedure, but it also improved the timing and speed of getting to a definitive answer for the patient. So really, really great stuff. Thanks very much.
Sure.
So, great example, Brett, and thank you. So next up, we've got Dr. Ken Sachs, and Ken works in our he's a medical oncologist himself, and chose to join eviCore a number of years ago, and he works in our medical oncology program, which is responsible for reviewing the drug combination therapy that's used to treat our cancer patients. So Ken, welcome. I'm glad to have you here, and take it away.
Thanks, Eric, and welcome to everybody, and thank you for joining in. It's a pleasure to spend, at least for me here in Boston, a beautiful afternoon. So the story I'm going to tell involves a young man who was unfortunate enough to develop metastatic lung cancer in his early 30s. Molecular testing of his cancer was performed, and it indicated that he had a mutation of EGFR. This mutation is associated with a prediction that targeted therapy will be effective. He was also positive for expression of PD-L1, which suggests a response to immunotherapy. In this setting, where both of these are positive, NCCN is quite clear that the preferred treatment is targeted therapy. The physician in question ordered a targeted therapy called osimertinib, and the patient was started on this drug and actually did very well for several years. But unfortunately, at age 37, he recurred with progression of his metastatic disease. The treating oncologist, understanding that he was PD-L1 positive, not surprisingly, recommended that immunotherapy be used to treat him. The immunotherapy he chose was monotherapy with a drug called pembrolizumab. As it turns out, pembrolizumab is not a recommended therapy in this setting, according to the NCCN guidelines. For those of you who don't know what NCCN is, it's the National Comprehensive Cancer Network, which publishes exhaustive guidelines for care, and their committees meet on a regular basis and update these guidelines regularly. So the fact that this was not recommended by NCCN is actually a nuance within the guidelines. And the nuance really applies to the understanding that the information that drives this recommendation is found in their footnotes. So the oncologist was informed that his request for single agent pembrolizumab could not be approved. And he scheduled a peer-to-peer conversation, which I happily took. In the conversation, I was able to point out to him where the nuance in the NCCN guidelines occur, and those footnotes that I referred to indicate very clearly that in the setting of someone who has both EGFR and PD-L1 positivity, for subsequent therapy, monotherapy with immunotherapy is considered inferior to standard care. The standard care being either a combination chemotherapy or chemotherapy plus immunotherapy. The oncologist was delighted to learn this. He agreed to accept an NCCN recommended chemo and immunotherapy regimen, which was started for his patient. This particular case was very instrumental for me and very rewarding because on one hand, I was able to steer treatment, a better treatment for a young patient whose chances of cure, of course, are small, but he could get a substantial duration of life based upon this combination of chemotherapy and immunotherapy. But I also was very happy to be able to educate this doctor about the nuances that appear in NCCN and how attention needs to be paid to footnotes as well as the large print. So anyway, thank you for paying attention and allowing me to share this case with you.
Great, Ken. Thanks so much. Another really great example. This one to me really speaks to the level of personalization. I mean, and this is an oncologist. This, all physicians are data driven, but oncologists seem to have an extra gear when it comes to data and details because of the nature of their disease. And the patient care is getting increasingly personalized. And to your point, NCCN updated their guidelines more than 150 times last year. So nobody that's in a busy practice is going to keep up with all of those, particularly when it's a subtle change for a rare subset. And so really being able to take that personal approach, and again, here was a perfect circumstance where what we actually recommended was more than what, more treatment than what the original proposal was, but based on the evidence, it was the right way to go for the patient. So potentially really good impact for this patient, because this combination chemo and immunotherapy, the data is really striking in lung cancer, and we're seeing patients live so much longer. So thanks for sharing that with us. Again, really outstanding. So thank you. So next up, we're going to stick with cancer for a minute, because next up we've got Dr. Dorothy Boo, who is a radiation oncologist and is one of our outstanding radiation oncology physician reviewers. And she's going to talk a little bit to us about a breast cancer patient that she had a particularly great opportunity to help. So Dorothy, welcome.
Gracious. I appreciate the opportunity to share our patient story that applies to the radiation therapy guidelines. The patient story I'd like to share is of a 51-year-old teacher who was diagnosed with a early stage breast cancer. After surgery, therapeutic radiation does play an important role in the treatment to reduce the risk of cancer returning in the breast by destroying any cancer cells that remain in the breast after surgery. The options women are provided are either a mastectomy, which is the traditional surgery to remove the entire breast, or a more breast-conserving approach, which would be a lumpectomy or just tumor removal. And that's where radiation plays an important part, and we've shown that therapeutic radiation does reduce recurrence risk and improve survival outcomes for these women. So this particular teacher, she was diagnosed with early stage breast cancer, decided to proceed with breast conserving surgery, and so saw a radiation oncologist who recommended 33 sessions of radiation therapy following her surgery. And so that was a review that came into eviCore. Initially given a partial approval, not saying that we are saying that part of the treatment is appropriate, but more reflecting that the radiation therapy guidelines have recently updated to align with the society guidelines and the reference National Cancer Society guidelines, which Dr. Sachs explained nicely, preferring a regimen called hypofractionated radiation therapy. To the breast is over about at least 25 to 33 sessions like this provider requested. The aim of hypofractionation is to destroy cancer cells in the breast, but with larger doses of radiation per day in overall fewer sessions, typically 15 to 19 are required. So on peer discussion, I did speak to the provider about the request and some of the details of this particular member's history and situation, and he did express that the patient did indicate that, she is a teacher, she's trying to get back to in-person learning, and she did express concerns about being able to commit to all these treatments. 33 sessions is over about 6 weeks. And the provider, after discussing the data, the evidence to support hypofractionation, many has shown that this is a successful treatment, just as efficacious as the conventional treatment we've been giving previously. He said that he has gotten comfortable with prescribing in a certain way, but he didn't feel that this member's case required a, exception for more treatments. He did admit that this shorter treatment regimen is appealing, and he would make this change in his practice going forward. So I think this is what makes eviCore unique. We do implement clinical guidelines, which are medically necessary and evidence-based, but we do also provide that opportunity to speak with the providers on a case-by-case basis and really talk through the case. And I think for this member's or this patient's request, I think overall she's has a better, treatment plan outlined. A shorter treatment course that will be just as efficacious as the 33 fractions that was requested previously.
Dorothy, great story again. And this, for me, again, how it's a different piece of how we can be a good partner here. Is here's a situation where there really is practice-changing evidence that's been widely accepted and recommended by the national societies, both radiation oncology specific and cancer overall. And this physician is clearly keeping up with evidence but is also conservative and really focused on making sure his patients get the best care. And he just hadn't gotten personally comfortable with that evidence yet. And so his patients were potentially receiving longer treatments than were necessary, more often than were necessary. And having the chance to talk to someone who's a true specialty peer, a radiation oncologist to radiation oncologist, and kind of feel safe to vocalize that and just have that conversation and to be able to help him get comfortable. Not only did it benefit this teacher, but helped him realize that this can benefit other patients going forward. So really, again, very powerful encounter again, and again, helping to align patients to the evidence and viewing this process as a partnership rather than an adversarial relationship. So thank you so much for bringing that to us today.
You're welcome.
Okay, great. So we're gonna change gears a little bit. Now we're gonna switch over. Next up, I've got Dr. Broca Tarshish, who is an obstetrician gynecologist as well as a medical geneticist, and she's one of our outstanding laboratory medical directors. And she's going to tell us about a really engaging encounter involving some genetic testing that had a really important impact on a particular young family. So, Broca, welcome, can't wait to hear about this story.
Thank you so much, Dr. Gracious, and thanks for the opportunity to present. So this was a request that came in to eviCore for full gene sequencing of a gene called ABCA12 for a 27-year-old male that was requested about a month and a half back. And homozygous mutations, or 2 mutations in this gene, are associated with a severe life-threatening autosomal recessive, meaning you need 2 abnormal genes or 2 abnormal copies of the gene in order to have it. The form of ichthyosis, which is a severe skin disease called harlequin ichthyosis. And this causes increased infections, temperature instability, because the skin is just not intact. So the clinical notes contain documentation that the member's son had been diagnosed with harlequin ichthyosis as a newborn in 2019. And they did genetic testing on this baby, and they found 2 disease-causing gene errors or mutations in the ABCA12 gene, which was a diagnostic of harlequin ichthyosis along with the clinical diagnosis. So the mutations that they found, or changes that they found, were a point mutation, where there's sort of a typo in the DNA. One base is switched with another base. And the second mutation was a deletion of 2 exons, where a portion of the gene was missing. And having those 2 changes caused this baby to have this disease. So genetic testing was recommended for the parents at the time because they needed to confirm that each parent had a change in the gene, and each parent passed it along, rather than one parent had a change and passed it along, and the second change was new in this baby. This would very much affect the chance of this happening again in another pregnancy. If both parents had the change, then there would be a 25% or 1 in 4 chance of them having another affected child. If only one parent had it, then there would be the chance of them having another affected child would be pretty small, just above the general population risk, and it's a rare disorder. So they went in for preconceptual counseling, and the clinician ordered testing for the father with the intent of also ordering for the mother. And the clinician ordered ABCA12 full gene sequencing. So this was problematic for 2 reasons. One, it was excessive. The appropriate test to order would be the known familial mutations, or the gene errors that were found in the child. And the other issue was that the second mutation, or the second gene error, wouldn't even have been found on full gene sequencing. The mutation that was a typo would be found, but the mutation that was caused by part of the gene being missing would not be found on this type of testing. So that could be misleading. In that case, if it was ordered on both parents, only one parent would be identified to have a mutation, and they would think the recurrence risk was very low versus 25%. So this testing was denied because it was inappropriate, and I had a peer-to-peer with the ordering clinician, and I discussed the issues with the order, and she actually said, I understand that, and that's actually the type of testing that I wanted to order, the known familial mutation that was found, mutations that were found in the baby, and I just wasn't sure how, so I just ordered sequencing. So I explained exactly which CPT or lab procedure codes were needed in order to order the correct test, and because I helped her understand the correct codes to order, she was able to submit another request, and that testing was able to be approved, and it was the appropriate and most informative testing.
Great, Broca, thanks for that. Again, really, really powerful thing. So just we're trying to do the right thing. The physician already was trying to do the right thing, but didn't have the the really detailed, nuanced clinical knowledge to understand the correct coding and ordering, because the lab tests can get really complicated, and just being able to say, yeah, that's what I wanted to do anyway, and here, thanks so much. It's again really powerful, and again potentially really scary for that family, right? If we had just done the sequencing, the father might think, hey, we're good to go, and miss the deletion, and then have another child and be surprised by that, rather than kind of going in with eyes open about their decision making. So really, really appreciate you sharing that one with us. Again, shows a lot of the diversity and how we can have a positive impact. So really appreciate what you do every day. So thanks again. We're going to pivot now. Again, I've got another one to share with you. I've got Dr. Joe Weiss joining us. He's a gastroenterologist and is part of our gastroenterology program. And he's going to tell us about an opportunity to to help steer a diagnostic workup in the right direction for a new patient. So, Joe, being a gastroenterologist, affectionately likes to be known as GI Joe. So, GI Joe, welcome and take it away.
Thank you so much, Dr. Gracious. Abdominal pain is a very common complaint, and this case is a 59-year-old gentleman, and I consider not year old, it should be year young. Anyone younger than me, I consider young. So he's a 59-year young gentleman who had abdominal pain over several weeks. It was colicky, involved the right upper quadrant of the abdomen. He did have a prior history of an upper GI endoscopy 5 years earlier, which showed gastritis. He was seeing a gastroenterologist, and I suspect the gastroenterologist was impressed with his past history of gastritis. Maybe it's a recurrence. So he ordered a repeat upper GI endoscopy, and while he was doing the endoscopy, also ordered a colonoscopy. So here we have two involved invasive procedures suggested. But on review of the clinical record, the story was of right upper quadrant colicky pain. Pain that was aggravated by eating fatty foods, relieved by fasting. It certainly sounded more like biliary colic related to the gallbladder, perhaps gallstones. And the diagnostic workup for that type of pain should include an abdominal ultrasound as the initial non-invasive, easy-to-do study. So we suggested that rather than proceeding with an upper GI endoscopy and a colonoscopy, that an abdominal ultrasound would be an appropriate initial step. If the ultrasound didn't show gallstones, which I suspected, then another approach prior to invasive procedures would be a therapeutic trial of acid-suppressing medications such as the proton pump inhibitors, and now that we know that stomach infections related to an organism that they received the Nobel Prize for identifying a few decades ago would also be appropriate. There are other approaches rather than proceeding directly to invasive endoscopic procedures. I think as gastroenterologists, we're very comfortable looking inside, and we're very fond of our skills at endoscopic procedures, but we tend to forget that these are invasive procedures. They're involved. There is a risk, although the risk is slight, the risk is real. So for the individual patient, this was an opportunity to have a painless, easy ultrasound that may well provide the answers, or a therapeutic trial rather than going to more involved invasive procedures.
Great, Joe. Again, great example. Here's another one where it's so easy as physicians where we get stuck, and we think, oh, we'll just slip a scope in. I do it every day, all day, and the patient's like, oh my gosh, I can't eat, and I gotta do all this prep work, and I'm losing a half a day of work, and I can just get an ultrasound, and that's gonna be good enough. Really, really powerful impact. And again, it's not taking away the need to do a scope later on if necessary, of course.
Absolutely.
But if there's a chance we can find out what's going on with a simple, less invasive test that can be done much quicker, really good for everybody.
Absolutely. I'm convinced a gastroenterologist should not have any job insecurity. There are plenty of procedures to go around. We don't have to worry about that.
Yeah, absolutely. Shorten the wait time for those that are actually on the schedule for it by getting it out of the way. No, totally agree. No, thanks very much, Joe. Appreciate you joining. So next up, we've got Dr. Richard Friedman, and Richard's been with us a long time. We're so pleased to have him. He's a general and vascular surgeon, and he works really diligently for us in our radiology program, which is a very high volume program. I'm sure a lot of you participants on the call interact with our radiology program as much as anything. And Richard's got another really great story for us. So Richard, glad to have you with us, and you're up.
Thank you very much. My case involves a 12-year-old girl who was complaining of low back pain. Am I on, by the way? Can you hear me?
Yes, I can.
Oh, didn't know about the mute button, sorry. So when she was seen by her doctor, he also elicited the fact that this pain was beginning to awaken her from sleep. Now, normally in a 12-year-old girl with back pain, a trial of 4 weeks of conservative therapy would be tried before any diagnostic testing or imaging methods would be used. But with the pain at night awakening her, this is a red flag that may show a more serious situation. And the question is, where do we go from here? The doctor appropriately did an X-ray to exclude skeletal abnormalities, and this was normal. And I was involved in the case because his next request was for a CT scan, CAT scan of the lumbar spine. An MRI non-contrast of this area is far superior in visualizing soft tissue structures, tumors, infection, disc disease. CT may be better for some bony detail, but certainly not the appropriate study. After speaking with his PA, and she excused herself and went back in to speak with him, they concurred, and we built that case. Now, a couple of features to stress here. One is we did recommend the more expensive study, and the cost is never a concern when we're trying to get the right imaging study for our patients. And we avoided the patient getting unnecessary radiation. You think of a 12-year-old getting pelvic irradiation equivalent to maybe 50 chest x-rays, and the possible deleterious consequence as she gets older, even cancer-producing consequence, that was a major gain for her. I just want to anecdotally point out that I'm frequently told that the reason CT is being ordered is, quote, we thought we'd get it easier than an MRI, which may in some companies be true. It's not true for us, certainly. But think about the paradox. She gets the CT, it's read very well, and the conclusion is suggest MRI. So now the patient has undergone unnecessary radiation and the cost of both a CT and an MRI. So it's not useful in any regard. So I hope this has been instructive, and it's been a pleasure being on this panel. Thank you.
Yeah, Richard, thanks for joining. And this is it's such a great example of something that we see multiple times every day. Here's an opportunity to basically do the right thing. We're focused on making sure the right thing gets done first, and there's still cost savings here, but the cost savings isn't the MRI. The cost savings is the CT that was never going to help drive the decision, even though it's cheaper to do than the MRI in a lot of places. It's costly in terms of money that didn't need to be spent, and the delay in care, because potentially if there was, for instance, some spinal cord pathology, the CT might not pick it up very well, and that delay in care and the time for the CT to be done and to have it read and not find anything, and then the symptoms not to resolve to get an MRI, things could progress pretty quickly. So again, really just, thanks for doing what you're doing, and it is helping to steer that in. I've, in my days working cases myself earlier in my career at eviCore, I can't tell you the number of times I had people just express shock, like, "What, you mean you give me an MRI now?" I thought, well, I just did the CT because it's cheaper. I thought I could get it done, and no, I'll do the MRI. That's great. So that's been something I've really gotten a lot of pleasure out myself, and being able to have the clinical and intellectual, autonomy to really look at the evidence and write the guidelines to say this is the best thing. And the business leaders say, great, that's the best thing for patients, and that's our model, that's our business model, and we just do that over and over again. So again, thank you for being here and sharing that story with us. Again, we've got a really broad group here today, and I'm going to shift specialty again with you. And I'm really pleased to introduce Dr. Mark Hayes, who's one of our cardiologists and works as a leader in our cardiovascular program. And he's here to talk about a really rare case that had a really interesting pivot and outcome. And I'm really pleased to give Mark a chance to share it with you. So, Mark, glad to have you here. Take it away.
Thank you, Dr. Gracious. It's an honor to be here. So my story is about a 61-year-old gentleman who was referred to a cardiologist for shortness of breath with minimal exertion. They had gotten an echocardiogram on him, and his heart function was normal. The valves all looked fine, but his heart muscle was somewhat thickened. And so when we see a thickened heart muscle in an ultrasound, sometimes that'll be associated with a long history of high blood pressure. This gentleman did not have that. When the cardiologist was talking to him, he noticed he had a history also of carpal tunnel syndrome, which typically does not bother cardiologists. However, in this setting, it raises suspicion of something called cardiac amyloidosis. So amyloidosis is when protein deposits form in the heart and the kidney and different parts of the body where they're not supposed to be. So this cardiologist wanted to assess for that. What he ordered was a cardiac PET metabolic study, thinking that might help. Now, we use the PET metabolic studies in cardiology to look for scarring of the heart after a heart attack, but he thought it might light up in this area. And so when he and I were chatting about this, I explained to him that the PET scan really is not going to be of much benefit that's really the best study for this is a cardiac MRI. He was in somewhat of a remote area of the country and did not have access to cardiac MRI. So we chatted about what he did have access to, and he did have a gamma camera near him. So we talked about doing something called a technetium pyrophosphate scan. And this is an older study that's been around a long time, but over the past 5 to 10 years, it's really shown that it is very beneficial in looking for amyloidosis in the heart. So we talked about doing this study instead, and he was very pleased with that. So we were able to redirect him to a study that would be easier for him to obtain and hopefully help him rule out this condition for his patient.
Yeah, no, it's great, Mark. It's a great example of, you know, diagnostic accuracy here. I mean, here's a really rare condition, and, you know, it wasn't immediately, you know, at the front of anybody's mind, what's the best way to look this up, but we've had the time and focused energy to really look into these rare conditions and really investigate the evidence and to have guideline content that already supports something even as rare as this. And one of the things I think we'd shared in the prep that I want to make sure the group gets to hear today is that this is particularly powerful for this patient because it wasn't so many years ago where really making this diagnosis was more of an academic exercise because it just to give an explanation, but there wasn't a whole lot we could do. And I think in the last few years we've had some really kind of exciting treatment advances that would actually potentially allow getting this patient into a treatment at an earlier stage of disease burden and potentially, you know, generating a better outcome for him. And, you know, I don't know if you want to speak to that at all, but I think that was a really cool part of this.
Yeah, probably 5 to 10 years ago, we only could treat the symptoms of this. So people would develop heart failure and renal insufficiency, and there was not much we could do about them. But over the past several years, there have been new treatments that are actually disease-modifying therapies that can stop this in its tracks. So trying to find this condition now, especially early on, there are options we have that can treat these patients now.
Yeah, really, really awesome stuff. Thanks for doing what you're doing and being here with that. I think that sounds like even from the encounter, that physician was particularly happy to know that there was a more specific option and even better that it was available at his facility. So I'm sure he called up his nuclear medicine department and he said, "Yeah, we got that. I'm surprised you knew to ask for it." It's an oddball one for sure. So thanks for bringing that to us today. It's a really great one. All right, and now, so thanks again. We've got one more story to talk through with you, and I've saved a really good one for the last because it's a different pivot for us. And I'm pleased to introduce Dr. Amanda Keel, who's a physiatry physician and works in our post-acute care durable medical equipment programs. And she had the opportunity to engage with a patient that was very timely for this year around planning for leaving the hospital. And I don't want to steal her thunder, so I'm going to introduce Amanda and let her tell this great story. Amanda, thanks for being here today. Take it away.
Well, thank you very much. And I think probably just saying that everybody will know what we're going to talk about since it's timely for this year. Anyway, I had a 79-year-old female who presented with a 3-day history of fever and shortness of breath. She came in from her assisted living facility, and apparently they'd had an outbreak of COVID-19 at the facility. She had a fever of 101.1 in the emergency department, was requiring oxygen, and her chest x-ray was consistent with what we found with COVID-19. So she has a history of plasma cell dyscrasia, which is a bone marrow problem, and she'd already been on steroids and an immune modulating medication for this. They started her on IV steroids to switch that, and they had her see infectious disease. On the day 2 of admission, she was started on remdesivir, and then on day 3, she was given the convalescent plasma. So she really got the full treatment for her COVID-19. On day 3, they actually asked for admission to an acute inpatient rehabilitation facility. And she was below her level of function. She normally was pretty independent at her assisted living facility. At this point, she's only walking 6 feet. She's needing help with her dressing and her toileting. And so it was looking like she might need acute inpatient rehabilitation. She's still requiring oxygen. And part of the acute rehab needs are you have to need more than one therapy, so like both PT and OT. You need to be able to tolerate 3 hours of therapy a day. you need to be relatively medically stable, but still be medically complex enough that you need to see a nurse frequently and a physician frequently. So it was looking like she was going to meet all those guidelines for acute inpatient rehabilitation. But when reviewing the medical records a little bit further, it looked like on that day she was still having a fever, she was still 101, she was still requiring oxygen, she was feeling more short of breath, and her white blood cell count, her infection-fighting cells, were actually decreasing to a fairly significant level. And so there was a concern about whether she was really ready to leave the hospital. And so that discussion was had that it would be beneficial for her to stay in the hospital at this point. And I did actually get updates from her. 6 days later, they sent in another request for acute inpatient rehabilitation. And in looking through these records, you did see that 3 days after the initial request, her oxygen levels were even worse. She was now requiring up to 4 liters, and she'd only been on about 2.5 at the initial request. But now she was still having a fever at that point. And 3 days after that, now she's afebrile. Her blood work is all within a normal range. She's doing much better, actually, with her therapy. She is needing less assistance, and now she can walk 20 feet, still needing help with her dressing. So now it was looking like she was stable. She can handle the 3 hours of therapy a day, and now she's ready for acute inpatient rehabilitation. So if she had gone to acute inpatient rehabilitation initially, she would have most likely been discharged back to the hospital within a relatively short amount of time, and if she had not been discharged back to the hospital, we know with COVID-19 that some of these things can be disastrous effects. And so it was really beneficial for her to stay in that higher level of care and receive the appropriate medical care before going on to rehabilitation.
Amanda, really great, timely, complicated story. And here's a perfect example. I mean, there's so many, the right thing to do for the patient was to spend more money in the short term, keep her in the higher level of care where she has more ability to respond quickly. I believe this patient had an underlying minor problem with her bone marrow in the plasma cell area, so had a little bit of low lymphocyte count, which is so important in fighting those viral infections. And with her bone marrow suppression, she's at somewhat additional risk for some secondary infections and secondary bacterial infections, which being in a facility has a slightly higher need for, and being in an acute care setting where somebody can respond more quickly to her. And throw some broad spectrum antibiotics on board if we get new systemic symptoms, really, really critical. So, and again, so all of a sudden, just 3 more days and 4 more days and things smooth out. And all of a sudden, this transition back to inpatient rehab is much smoother, much safer, much more likely to succeed. And again, really focusing on doing the right thing for the patient, pays dividends.
And definitely, they actually, on one of the follow-up chest x-rays, found bacterial pneumonia as well. So she was started on those IV antibiotics right away rather than risking any delay.
Yeah. And just in that half a day or a day it could take to get from discharge from the inpatient rehab and back into the hospital and reassess them back up, you can slip a long way down the slide in that short period of time. So really, again, fantastic work, and really appreciate you sharing that one with us. It's again another particularly powerful story. So we've used nearly all of our time today, and it's just we could do this all day. And I hope that as an audience you've gotten to hear a few things. One, I hope you've gotten to hear the passion and the personalization that the eviCore physicians are bringing to their job every day. We care a lot. And we're here to help. We're here to be a partner. I know as engaging with prior authorization is frustrating sometimes and slow sometimes. And there's certainly opportunity for things to be operationally better and more efficient and smoother. And we've been talking about those over the last few months, but I also didn't want us to lose sight of the really impactful thing is that there are patients for whom prior authorization is disease-changing and potentially even life-saving, and the work that you're doing to engage with that to support the physician staff in your office is helping that patient care. It's helping all physicians with their blind spots, both those seeing direct patients and us at eviCore. That exchange of information that happens on the peer-to-peers works two ways. And both sides rely on that, and it's a team effort, and we're all here to take care of everybody. I've seen this come to light really powerfully this year during COVID-19. We've had folks reaching out and saying, this is off the wall. I'm trying to figure out how to do this with COVID. You know, does this make sense? I know there's no evidence, and our clinicians have had to really stretch themselves as well and really think outside the box and how do we respond during this pandemic. And it's been really inspiring to watch, and I'm very, very proud of both our team as well as the physician community at large, just for the way everyone has leaned in. So I want to thank everybody for attending. Really appreciate you hanging in and listening to these stories. I hope they've given a personal face to this process that we all engage in every day. And you know, with the season that we're in, I'm thankful for our team. I'm thankful for everybody out there taking care of patients and for being on the call. I appreciate you being with us, and I hope you have a great holiday. Thank you.
This concludes our conversation. So this webinar was recorded and will be available on demand by visiting eviCore.com. Please remember to register for our upcoming webinars. You will receive an email invitation with the opportunity to do so. If you would like to learn more about our capabilities, please reach out to sales@eviCore.com. Thank you again, Dr. Gracious, and all our clinical panelists for sharing your expert knowledge with us today. I hope that you all have a wonderful rest of your day, and this concludes the webinar.